Hello, everyone. Good evening. Or as I just read, good morning in Ireland. Wow, it's dedication, 3 a.m. How's everybody doing today? We'll be getting along in just a few minutes, kind of let some people sign in, join in, and we'll get going. Can you hear me all right, Cameron? That volume's all right? Nice. I'll do my best, Cameron. I'll do my best. All right, I'm going to start to share screen. That show up all right, Cameron?
Good to go.
Go. All right. All right. Is Chris on? Or Chris will be on?
I am on. I'm ready to go.
All right, guys. I'm going to end this poll. All right. Okay. All right, guys. How's it going? It is just now 7 o'clock, so we will slowly get started with an intro and give people time to join. My name is Dr. LeMoine. I am one of the co-founders of PhysioU, and today we'll be talking about rotator cuff pathology. Yeah, so welcome if this is your first time joining one of our webinars. I think this is our 10th overall that we've done over the course of the summer, where we've just kind of picked a different topic, a different joint, then kind of really discussed it in depth partly using the PhysioU app, and as well as just kind of partly using evidence-based practice and clinical experience. So that is our goal of how to help kind of integrate what you guys have been learning in the clinic or in the classroom into the clinic. Cameron and Chris, thank you guys so much for being here as well. They are two third-year doctor of physical therapy students that kind of will help man the chat box. So if you ever have a question along the way or a comment along the way, please feel free to put it in there, and they will help to kind of organize stuff and ask them as time we're able to. Or by all means, if you want to speak up when I ask questions, feel free to unmute yourself, answer at will. But then maybe remember to mute yourself afterwards, just because it gets a little noisy with everybody's unmuted. All right, so again, so let's see. I'm going to first pull up the app part. All right, so if we start, right, if we go to PhysioU, what we'll be living, most of the time we'll be living in this clinical pattern recognition for orthopedics. And I'll be bouncing back between that and the PowerPoint, right? But we're talking about rotator cuff. So we'll go to shoulder, right? Clinical pattern recognition. So there are no clinical practice guidelines for rotator cuff or impingement yet. The only ones they have are adhesive capsulitis mobility deficit and then radiating pain. They're working on others. I think the next one coming out is shoulder instability. Then after that will be the impingement. So there's no real guidelines that APTA has put out yet. So really what we've done is just comb all the literature to kind of create, using the best of literature, create a pattern for us. So let's say we click on shoulder pain, right? Whether it's localized or maybe a little bit of radiation into the biceps region, which is or deltoid region, which is very common, right? When that pops up, you should have a differential, right? Just from pain location itself, it doesn't really help us too much with the shoulder pain, the shoulder, right? Whether it's biceps tendonitis or AC joint or subacromial pain syndrome, and whether there's a labral tear or maybe it's a referral from the neck, location itself of just in the shoulder isn't too helpful. Now, if it radiates down the arm or it's shooting up into the neck, that's helpful because then it kind of helps lead us more towards a cervical or nerve component, right? But if we click on subacromial pain syndrome, if we're talking about rotator cuff, someone can get a rotator cuff tear through really two mechanisms, right? What do you guys think those two mechanisms are? Think of the patients you guys have seen or you've read about, and someone has a rotator cuff tear. How do they get it? Feel free to unmute yourself and talk, or type it into the chat box.
Motor vehicle accident, trauma, wear and tear, overuse.
Perfect. That's right. So one is going to be like a macro trauma. So macro trauma meaning they know exactly what they did, when they did it, right? Most common one is going to be a fall, or grabbing onto something to stop yourself from a fall, or grabbing on to try to stop something from falling, right? So this quick sudden contraction, right? On the second part, you have these micro traumas. So a general overuse, or what we would like to say is a misuse, right? So maybe it's not that they're using their arm too much, it's just the way they're using their arm. So those are the two big avenues for a rotator cuff tear. Trauma and really what's called subacromial pain, so impingement, which then leads to a tendinitis, a tendinosis, eventually a tear, right? So if we talk about prevalence for impingement, right, pretty darn common, right? It is the most common cause of shoulder pain that we will see. So the goal is to try to become good at diagnosing and treating this type of patient, right? However, right, if we think about it's the most common type of shoulder pain, we also want to understand that it's actually quite common to have rotator cuff pathology and not have any pain, right? So if I kind of bounce back to this one, right? Here's a pretty cool study that just looked at prevalence of rotator cuff tears over the decades. And really a quarter, 25% of people in their 70s have a tear, almost 40% of people in their 80s, right? So it's pretty common to, as you age, to have this wear and tear and eventually have a tear in your rotator cuff muscle. What's interesting is that really majority of these people, as they get older, those tears are asymptomatic, right? So 50% of tears, if you're 50 years old and you have a rotator cuff tear, right, 50% of the time it's asymptomatic, right? So the way that they did this is they took 1,000 people, right, from one city, and they just gave all of them shoulder MRIs. And they said, all right, who has shoulder pain, who doesn't have shoulder pain? And in the 60-year-old group, more than half of them without pain more of them that have no shoulder pain have a rotator cuff tear than don't. So really, it's more common to have a tear without symptoms than it is to not even have a tear. So it's kind of considered age-related findings and norms. So that's good on our standpoint, where somebody's coming in talking about this rotator cuff tear. We can already say, hey, you know what, prognosis is okay, because there's a lot of people out there that are pain-free with the same exact diagnosis you have, right? Right. So that's good to know, right? If we go to clinical findings, right? So clinical findings would be us trying to decide, how do we know if this person has a tear, right? So what do you guys think? What would be some things you'd be listening for in your subjective that may tell you, I think this person has a full rotator cuff tear? And can't use trauma, because we already got that one. You've already said trauma.
From Joel, painful arc.
Okay. All right. So patients don't necessarily come in saying painful arc. They come in saying, right, it hurts when I reach into those angles. So when they reach into that 90 degrees, 120 degrees, it's painful, right? Maybe it doesn't hurt when they're lifting above their head, but it hurts when they reach out because it's that angle of arc. Good. What else?
We have a lot of objective findings, such as lack of full range of motion, decreased strength, tenderness, pain with palpation, specific point pain, popping in the shoulder during movements.
Okay, so maybe clicking right. What about if we're sitting there with our patient, we're not doing objective tests, and we're asking them questions, right? What would we expect them to tell us about when they have their pain if it's a full rotator cuff tear, right? There's a great study that came out that said, right, these are kind of the three things we're looking for. One of them being trauma. Check, you got that. What are the other?
I have pinching.
Okay.
Pain at night.
Pain at night. That's a big one, right? Yeah. So pain at night.
Trouble sleeping.
Trauma. So that would fit into the pain at night. So sleeping, pain at night. One other one has to do with their demographics.
Diabetic?
No, age over 50. So if you have a 55-year-old person walking in that tells you they fell on their arm and it hurts mostly at night, right? Chances are they have a full rotator cuff tear. Right? That's what the study shows. Doesn't mean everybody has it, but that was the classification for this type of population. Right? Again, that would be the trauma people, right? So what about your objective findings, right? You guys kind of started, sound like you guys are throwing some stuff out, right? Let's first, instead of looking at full rotator cuff tear, let's look at impingement first, right? So subacromial pain syndrome. What would be those key tests that you'd want to do for impingement?
Jobs?
Jobs, okay, good. What else?
Hawkins-Kennedy, full can, empty can, NIRS.
Yep, good, nice. And then I think you guys already talked about, but painful arc is a big one, right? So, yep, I think you guys said, so you have arc of pain, right? You have NIRS test, right? But I want you to look at these sensitivity and specificity numbers with NIRS test, right? So if you're taking someone into full flexion and abduction, you're overpressing it, right? Not the craziest numbers. How about Hawkins-Kennedy? Same thing. Those numbers don't look too sexy, right? Right. So you have a lot of these things that aren't the greatest. However, if you put all of those things together, right? They did a study that said if they have a positive arc of pain, a positive NIRS, and a Hawkins-Kennedy, now we're looking at likelihood ratios in the 10 and specificity up into the 90s, which is way better, right? So we want to think about sometimes with these tests, we want to group them together because then it's more meaningful, right? So yeah, so Hawkins-Kennedy, NIRS. And then the other one is when there is impingement, most of the time there's going to be some type of rotator cuff involvement, right? Majority of the time it's going to be the supraspinatus that goes through the subacromial space, but even the other ones, infra, teres, those can also be irritated. So what should be inside that is also just an MMT of your rotator cuff, right? So arm by side. Okay. So again, if we think about Hawkins, painful arc, if you add an MMT to it, here's our likelihood ratios. When all three are negative, your negative likelihood ratio is almost nothing. That's all amazing. So if you can do all three of those tests and they're all negative, they do not have shoulder impingement, right? So think of it as maybe like the sacroiliac joint cluster, the SIJ cluster. They kind of work together. By themselves, they're not as helpful. Okay, good. So if we back up, physical exam, key findings, right? We looked at impingement. So what about large rotator cuff, right? That's kind of the topic of today's. If we're looking at a large rotator cuff tear, what were some of the objective tests you'd look at with that?
Drop arm test.
Good job. Drop arm test.
Painful arc.
Okay. So painful arc doesn't help us diagnose a rotator cuff tear. It helps us maybe a rotator cuff pathology. That painful arc is related to impingement, which is related to tendinopathies.
External rotation lag sign.
Good. So internal rotation lag sign, drop arm test.
Weak and painless with MMT.
Awesome. Okay. So you're thinking about the Sacroiliac square, right? So it doesn't really hurt them, but they have no power. Chances are the muscles not touching each other anymore.
Kevin wants to know if infield would help you out.
Not necessarily. Like if it's an acute thing, you'd expect to have a painful end feel. So as you're doing it, they won't let you go there because it hurts too much, because normally there's a lot of, if it's acute, there's a lot of bursitis going on because of inflammation in the area. But a stiff end feel wouldn't necessarily help us decide if it's torn or not torn. There's one more you guys are missing.
Infraspinatus MMT.
Infraspinatus, yeah. So the MMT, which would be that you guys talked about, but I don't know. I think you guys said the internal rotation lag sign, but there's also an external rotation lag sign, right? So we'll click on that, right? So, all right, you guys nailed it with drop arm, right? So your drop arm test, right? So again, you take the arm to 90 degrees, ask if they can hold it, right? Some studies show that it's in neutral, so palm down. Some studies show that it's an internal rotation, right? If they can hold it there, right? You bring them up there passively, they can hold their arm, and then you can even add resistance to make it even more sensitive. And if they can hold it, negative. If it hurts them, negative. right? It's not a test for pain. It's a test, can they hold the weight of their arm at 90 degrees of abduction? If they can't and it drops, hence the name drop arm test, then yeah, okay, positive. What muscle is that for?
Supraspinatus.
Good, supraspinatus. So the most commonly torn one. Good job. All right, external rotation lag. Again, all of these tests, you're passively taking the patient there and then asking them to hold it. So you're trying to take away any type of impingement or any type of instability. You're passively taking them to a range, and then can they hold it? So pure power. So here you're taking them to full external rotation and a little bit of abduction, right? And then ask them to hold it, right? And if it falls in, if it goes into internal rotation, maybe this is a good one to play for
with the
you guys.
patient seated, flex the elbow to 90 degrees, abduct to shoulder 15 degrees, and maximally externally rotate the humerus. Ask the patient to hold the hand in this position. A negative test would be if the arm does not move and the patient is able to maintain this position. A positive test would be as you ask the patient to hold it, the hand falls into internal rotation.
Perfect, okay. Yeah, so that would be for what muscles? What muscles are we testing with external rotation lag?
Infra and supra, infra teres.
Infra and teres are our two external rotators, right? So arm by side, you test them both, right? But you can differentiate by going to 90 and doing an MMT at 90 if you wanted to kind of clean up a little bit. But technically, this is for both. So good job. And last one, internal rotation lag. So again, here we're taking the patient hand behind back, lifting it off of their back and asking them to hold it. Can they hold it off of their back? A positive test is they can't. It just kind of falls onto their back. They have no power to lift it off, right? One, what muscle are we testing? And two, what are some of the issues with this test? Right? What are some problems you think we get into?
They don't have enough internal rotation to get the hand behind their back.
Yeah, exactly, right? Often internal rotation hurts with shoulder pathology, right? It's one of those combined motions of extension, adduction, internal rotation. So we're trying to put them in this position and see if they have the power to hold it. A lot of times it hurts them too bad to get there. So they have a modified test. What's that modified test? Come on, you're on the spot, Andrea.
Oh, it's the belly press test. I'm
Okay,
sorry.
yeah. So belly press test, right? So this way you can still test the internal rotators without putting them into max internal rotation hand behind back. All right, the interesting thing is I've had a couple patients in the last 2 years actually with a subscap tear, both of them trauma, right? I haven't seen a subscap tear with just overuse. It's mostly trauma. And both of them were actually able to hold the belly press, but they compensate quite a bit. So it's a test you have to kind of pay attention to a little bit because they can definitely cheat and make it seem like they're holding with resistance. Right.
With the patient seated, have them place their involved palm on their belly and try to push their palm into their belly, firing the internal rotators of her shoulder. You're looking to see if the patient is able to maintain this internal rotation position of the humerus. A positive test would be if the patient flexes at her wrist and tries to use more of shoulder extension to push into her belly, which could mean a possible tear of the subscapularis muscle.
So if they go into shoulder extension, right, then they're using all of their wrist flexors to push into their belly, right? But what other big internal rotators do we have to help out? We have our pec, we have our lat, we have all these other big muscles that can help out. We don't have those things for our external rotators, right? So if someone has a torn external rotator, you can really tell. It's pretty quite obvious. But with internal rotators, they can cheat quite a bit with other muscles or with other shoulder positions. So we have to be aware of that. Good. Right.
Dr. LeMoine,
Yep.
quick question from the chat we have.
Yes.
Let's say someone has a positive painful arc. Would performing NIRS and Hawkins-Kennedy still be a beneficial test, knowing that they might be false positives due to that, you are bringing that patient up into 90 degrees of abduction?
Yeah, it's still valuable because the idea of a painful arc is that it gets significantly better at the top. So it should be less painful up here. So then if you add the overpressure of NIRS, then that would be like, oh, it's positive again. So because a painful arc would not be ouch, it hurts, it hurts, it hurts. It still hurts up here. Because if it already hurts, totally right. We're not going to gain anything by adding extra if it already hurts. So we're hoping it really is a true painful arc and that it only hurts in this 90 to 120, 130 degrees, and then it kind of goes away. And then I can bring it back on with overpressure, right? The other thing is with painful arc, it's often active that hurts. So they actively abduct, it hurts, or they actively flex, it hurts. But if I passively take them there, it often doesn't hurt, right? Because there's no contractile muscles. The subacromial space isn't being closed down. The scapula muscles aren't having to do all their work. So often it's not painful when I take them into 90 degrees of flexion. But then if I add the internal rotation for Hawkins, then it pinches it and it hurts again. So I totally agree. If it already hurts just going into that position and that position, we don't gain anything by adding the extra. Right? But we're hoping with a painful arc and someone that fits impingement very straightforward, right? They're by the book impingement. It shouldn't be painful here, and it shouldn't be painful here, or at least not very much. Maybe it's a 1, but then here it's like the 5. Right?
Awesome.
Does that clarify? Does that answer?
Yeah, perfect.
Okay. All right. You guys already talked about rotator cuff MMTs, right? And I think somebody threw out the if it's weak and painless, right, it would be the most likely to be a tear. But if it's weak and painful, it can definitely still be a tear. Just if it hurts, it doesn't mean it's not a tear, right? So kind of keep that in mind. So good. Right. I would say in my objective exam, which one do you think I kind of do first? Right. Someone walks in, I do active range of motion. Out of all these tests, what do you think I'm going to kind of do first? How do I prioritize this in the clinic?
Camden says drop arm.
Drop arm. Okay, why? Sorry to put you on the spot there, buddy, but why drop arm first?
He said the fastest test to perform.
Okay. All right, so good. So going for efficiency, not bad. Most commonly torn as well. So maybe you could say, right, go big or go home, I guess, right? Is there something I can do that would say, you know what, I don't got to do these big full tear tests, because these really are only tests for full tear. They're not tests for pain. It's can you or can you not do it? So maybe there's something I can do that tells me I don't got to do drop arm. I don't have to do external rotation lag. I don't got to do internal rotation lag. I can skip these full test tears. What do you guys think?
We have checked the MRI report.
Okay, so if you're lucky enough to have an MRI, right? If someone has a positive MRI, I'm definitely going to test these though, because now I'm curious, right? I'm always curious about this research that says sensitivity, specificity, and like, hey, this guy actually, we know he has. How often do we actually know truly what the diagnosis is? And now I can make this, unfortunately, make this guy a little testing guinea pig to see like how do these tests pair out. But I would say I'm going to first do an MMT with arm by side. If I test someone and they have really strong external rotators, really strong internal rotators, same as the other side, do they have an external rotator, internal rotator tear test or tear? No, I ain't got to do it. Right? If they can hold against abduction at 15 degrees and they're strong, I don't got to do these full tear tests, right? It's a person that's painful and weak with this testing, or then I'm like, shoot, is this a partial tear? Is this tendinitis? Or is this a full tear? Now I need to know, how bad is this guy's rotator cuff pathology? Is it a little bit or is it a lot? And that's where it comes in these full tear tests, right? So that's how kind of in the clinic we use them. Not everybody gets them. It's if you think this person has a full tear, because that's what they're good for. They're not good for diagnosing impingement or rotator cuff pathology. Full tear or not tear, right? Good, okay. All right, so if we kind of go back to our physical exam, right? So we've done rotator cuff and impingement were our two big ones today. Remember, if someone is acute, right, we need to sometimes go into this pain-limited shoulder exam. Sometimes it doesn't help us to MMT anybody. It doesn't help us or the patient to do all these tests. They already have a 7 out of 10 pain just hanging out there in clinic, right? So what are we going to learn or gain from doing these tests, right? So our mind should then shift to, right, this pain-limited screen, which means now we're looking more at what can we do to improve pain versus what tests are positive that make it hurt, right? So if I click on that, I think it's always important to bring that up, because even now, right, mentoring residents and fellows, sometimes we feel like we need to get more and more information because then we can help them more. But sometimes along the way of gathering that information, if symptoms are already irritated, we're just making it worse. So sometimes just looking at passive range, right? People like passive range. It feels good sometimes, right? They're guarded, painful shoulder, it hasn't moved in a while. We're assessing passive range, but we're also treating at the same time, right? Maybe looking at grade 1s and 2s. It's an assessment, but it's also a treatment for inhibiting pain, right? Talking about immobilization, if we're going to temporarily immobilize it. Maybe we need to tape the shoulder, right, to unload it, right? So we kind of start to steer away from any special tests, really, and go straight into what can we do to make them feel better, right? Good. All right. Physical exam. Okay, so that would be our key findings, right? We've now put on our diagnostic hat and we say, you know what? Impingement, rotator cuff tear, is it a large tear or is it a partial tear? How do we treat these people, right? How do we treat someone with a rotator cuff tear or impingement? What do you guys think are some of the more common treatments?
Scapula stabilize and strengthening.
Good. Yep.
Range of motion and strength.
Yeah. Common impairments. Yep.
From Kevin, acute equals immobilization.
Okay. Acute immobilized. Check. So if we are going to treat them, right, with strengthening, range of motion, maybe immobilize, what's the value of doing special tests in the shoulder then? If we know we're going to strengthen their scapular muscles, right, we know what's the value. We know we're going to maybe work on joint mobs and stretch pecs. What's the value?
To make sure what type of sling we're going to put them in.
Okay. So if we understand the pathology a little better, maybe the intervention can be matched a little better. Agree?
Provides us with the baseline.
Good. Okay. So some of the special tests that are painful, we can reassess them weeks later to see, hey, are they still painful? We're making progress. Check. That's good. So reassessments.
Identify the stretcher and intensity of involvement. Makes the patient feel better. Find specific deficits.
Okay. So yeah, patients want to know what's wrong, right? Patients often come and you ask them, so what are your goals with therapy? Sometimes it has nothing to do with getting better. It's just they want to know what's going on. And then you follow up with a question with, so if I tell you what's going on, do you want help fixing it or you just want to know what's going on? There's kind of like a little joke and they're like, oh, well, I want to make it better. But that's always their answer sometimes is, oh, I want to know what's going on. Great, good. So we can use that to help show patients that, hey, have a little bit more faith in us. We understand what's going on, right? Most research, if we're going to use evidence-based practice, most research is based on pathology, right? There's not research that says, oh, you have limited shoulder flexion. It's, oh, you have this type of diagnosis. This is what the interventions are, right? There's one more big one that you guys are kind of missing. Why should I do a drop arm test or an extra rotation lag test? Why should I do this if I think someone has a full tear?
If full tear, may need surgery. Compare bilaterally. Documentation. Insurance.
Good. Okay. So I think the one I liked the best out of there was, am I the best person to help this? Am I the best person to help this guy? Meaning, does he need a referral to orthopedics? Right? Studies show that trauma, being male, if you're less than 40 and you're active, physical therapy is not nearly as helpful as surgery. So someone who's younger and active and they had some type of trauma, rotator cuff tear, right? If that's me, right, I'm still barely under that 40 bill, right? I would want my therapist to send me to orthopedics for at least for a consult, right? Doesn't mean I'm signing up to have surgery, but it says, hey, if we use the evidence, it says that, surgery has good outcomes for that group, right? However, right, if somebody is over 50, diabetic, no trauma, right, outcomes are no different. Surgery or no surgery, they both improve the similar amounts. 5 years later, conservative group is actually better, right? So it's important to say, hey, we need to know who do we send out and who do we not send out, right? I kind of switch to this slide, right? So we talked about clinical pattern recognition, right? So we want, is there trauma? Is there night pain? Is there inability to raise the arm? Do they have impingement tests, right? Rotator cuff tests. We've done all those things, right? I'm going to skip this slide for a second, right? It leads us to conservative care. Are we going to treat this person conservatively, right? Because they get better. If they're over a certain age and they fit it, they get better. They don't need surgery, whether, so if you read that last sentence, whether treated operatively or non-operatively, right? How about 5 years later? What's quality of life look like, right? So 75% of patients that were treated non-operatively were still successful 5 years later, right? They couldn't say that for the surgical group. But again, remember the age, remember the demographics, right? Good. Okay, so let's go back to this one. Okay, so, right, we decided, you know what, this person, rotator cuff tear, but we're gonna treat them, right? It wasn't trauma, it was overuse or misuse, right? So we wanna look at some of the main faults, right? If we think of the shoulder blade has 3 main faults related to shoulder pathology, related to impingement and rotator cuff. What do you think those main faults are of the scapula, right? 10 years ago, they used to just call it dyskinesia. Your scap isn't working well, there's something going on, something funky, we'll call it dyskinesia. But now they've tried to kind of fine tune it.
Scapular depression.
Okay.
Lateral upward rotation, weaning, decreased upward rotation.
Good. And one more.
Tilt.
What's that?
Anterior tilt.
Bingo. Good. All right. Yep. So the top 3 are lack of upward rotation, right? Insufficient posterior tilt, too much of an anterior tilt, and then scapular winging or internal rotation, right? Depression by itself, right, doesn't show as significant to shoulder pathology, more cervical pathology, but depression with downward rotation, right? Studies show that it's a common fault that can be changed related to shoulder pathology. So if someone has upward rotation, they lack upward rotation, how are we going to identify that's the reason why they have shoulder pain? 2 questions. How do we know that's the issue? And B, what are some other impairments related to that?
We can do the scapular assist special test.
Awesome. Good. All right.
Does fixing it make it better?
Say that one more time. I'm sorry.
Does fixing the scapula, correcting the scapula, make the pain better?
Perfect. Good. All right. Good. Yeah. All right, so if we watch,
Observe the patient, elevate our arm above her head,
if we watch them reach,
and measure the scapular upward
right,
rotation.
we can look, one, do they even get enough upward rotation, right? Normal is 50 to 55 degrees based on which paper you're reading. Some say 60 even. The idea is they should upwardly rotate, right? Studies show that if it doesn't upwardly rotate, your subacromial space is smaller. So if it hurts, I'm going to then say, if I manually lift it for you, right? If I upwardly rotate it for you, what happens to your pain?
This can also be performed
right
by placing your thumb along the medial.
So there's 2 different ways to do it. One from the side and one from the back. Right? We're trying not to help the patient lift their arm, just trying to upwardly rotate the scapula.
Looking for a decrease in the pain.
Right? So if that's our upward rotation, right? And let's say it gets better, what other impairments would you guys want to look at? What are some reasons why they wouldn't have enough upward rotation?
Weak serratus.
Okay.
Poor posture, tight lats.
Good. Yep. So serratus is one of our main upward rotators. You guys know the other upward rotator?
Upper trap.
Good. And then one more. What's another upward rotator? Primarily when you're up above 100 degrees.
Levator scap.
No. Starts with a lower, ends with a trap.
Low trap.
Low trap, yeah. Right. So, yeah, so when we get up there, we have really 3 muscles that are helping us. Our serratus is our primary one, especially down around here. Our upper trap, especially if the scapula is depressed, the upper trap cannot help us upwardly rotate. Right? So we want to work on that. and then lower trap. So I'm gonna assess serratus, MMT. I want to check lower trap, right? MMT. Here's our serratus. And so I have a folder in my head that says, you know what, this person might have an upward rotation issue. I check it, I correct it, it feels better. In that folder should pop out a couple of key impairments. 1, what's their serratus strength? 2, what's their lower trap strength? 3, what's another one? What's another reason why someone's scapula wouldn't maybe upwardly rotate?
David says rhomboids are stiff or short.
Okay, perfect. Good job, David. Yeah, so maybe there's a muscle holding it back, right? Maybe they get all their stability from their retractors. So then when they raise their arm, they can't get any upward rotation. Think of a little bit, think more mainstream. That bone isn't moving the way it should move. Think of someone who maybe was immobilized for a bit.
Joint hypomobility, bony block.
Yeah, so maybe it's just scapulothoracic joint mobility, right? Remember when we lay them on their side and we're looking for, does the scapula even move? Now, if I move the scapula, right, and I'm able to move it just fine, then at least I know it's not a joint stiffness, right? I say, all right, this is a muscle control problem, not a joint not moving problem. Right, good, okay. So that would be our insufficient upward rotation, right? The second one was tipping, right? So insufficient posterior tipping or too much anterior tipping. How do we know that's an issue and what impairments come out with that folder?
Pec Minor length test.
Good. Pec Minor length, perfect. Yep, that can pull scapula forward. What helps keep it tacked down on the backside?
Weak lower trap.
Good, perfect, good. How do I know if that's the problem for why they have their pain possibly? Anything I can do to help confirm that if we spend time fixing this, it'll get better?
In posture, you can apply a posterior glide to the humerus and ask them to flex their shoulder, compare it to the other side.
Awesome. Yeah. So they raise their arm, they show you their asterisk sign, ouch, it hurts, right? You add that posterior glide or posterior tilt, they recheck it, it feels better, right? So there's a name of a fancy study, right? Scapular repositioning test, which you described. So good job, right? They've actually studied it and said, oh, this works so well, we should give it a fancy name, right? That's what they did. Good job. Right, and so you said lower trap, you said pec minor, great job. The third one is winging, or what now they've tried to really, we kept winging in there because it's still in all the textbooks, because the textbooks are all 10 years old, but now they no longer call it winging, it's really scapular internal rotation, right? That's kind of the term. Scapular winging is only used with long thoracic nerve palsy. So if someone says, oh, I have scapular winging, you think of it as like, oh, it's actually this neurological palsy. But it looks like a little wing. But yeah, okay, so again, that's the hardest one to change in the moment, right? It's hard to tack the medial border of the scapula down and have them still move. So that one's a little different. If we want to know if it's helpful or not, we try to have them turn on some of their muscles to see if that changes their pain. So just like the other two, we have them lift.
Observe the patient's scapulas as she flexes both arms fully.
Right, she reaches up. Maybe we see winging on the way up, or we see winging on the way down, and it corresponds to their pain. Again, it's hard to tack them down. So instead, what we're going to do is we're going to teach her to turn on maybe her mid-trap or lower trap, or we're going to teach her to turn on her serratus and have her like push into our fingers to see if we can get more muscle activation, and that will control the internal rotation. Right? Good. Perfect. Okay. So those are the primary reasons for someone having shoulder issues, right? What's going on with the scapula, right? They did a study that said over 65% of shoulder pathologies related to impingement, rotator cuff, instability, all of them really are related to what's the scapular cause. So how about if it is a humeral problem, right? There's two kind of faults at the humerus. One is an anterior glide or an anterior translation, right? Studies show that people with impingement may have a couple more millimeters of humeral head anterior glide during reaching than controls. And then the other one is excessive internal rotation, right? That's a pretty common one, that people that have really tight lats, tight pecs, they kind of are hanging out in internal rotation. So we know that when you internally rotate the shoulder, especially when you get to that painful arc area, right, there's less room, right? We need to stay externally rotated, right? It's one of the easiest ones to kind of correct in the clinic. Someone reaches up and they're reaching up either pinky first or elbow first. You're like, oh man, that really hurts. And you just tell them, you know what? Externally rotate first, now lift up. Oh, it's better, right? So that's kind of an easy one. And now we get to think about, why is this their go-to? Right? Why do they move like this? What can I do? Right? Because you already took their pain away, but think about what's driving this. So what would be driving someone? It's easier for them to reach here than it is like this. What do you guys think?
Deanna says weak external rotators.
Exactly. Awesome. Yeah. Right. Anything else?
Earl tag teamed with her and said the same thing.
Okay. Is there something that would make the external rotators have to work harder to get to external rotation? Right? Maybe they hang out here because it's just easier. Right? And I don't like doing this because I have to work really hard against something. Maybe I'm not a weak guy. What am I working against?
We have tight internal rotators such as the pecs and the lats.
Good. Yep. So especially once we get up here, right? If someone has problems with flexion and they dive into internal rotation, we think which muscle? What internal rotator gets tight as we go into flexion?
Lats.
Right. So let's say flexion's no issue, right? It's abduction that hurts. And I go into internal rotation with abduction. What muscle gets tight? What internal rotator gets tight?
Pec.
Pec. Right, good. Right, so how about arm by side? Let's say it's really arm by side. I can't really externally rotate well down there.
Subscap.
Subscap, yeah, right. Subscap is a really stiff internal rotator, arm by side. And you need to have external rotation by your side in order to go into abduction, right? So great. So we've kind of learned to be like, hey, you know what? Just by having them turn their arm out, does it change? If it does, let's investigate why. Is it because their subscap's too stiff? Their pec's too stiff? Their lat's too stiff? Maybe their teres is too stiff, right? So there's all these things that would pull them into internal rotation. But I like how you guys added, it could just be weak external rotators as well. So that's awesome, right? So how much of the scapula are we treating here? Not much, right? So if we've looked at the scapula looks solid, it upward rotates nicely, has a good posterior tilt, realize maybe we don't need to, even though that's the majority, we don't need to, right? The last one we'll talk about is an anterior glide, so an anterior translation, right? So this is the person that reaches up, and we want to know, maybe they have a little bit too much of an anterior glide, right? What can I do in the moment to help see if I correct that, it'll feel better? I can add a posterior glide, right? Think about the test on the table, right? Anterior apprehension, posterior relocation. It's very similar to that test, except you're doing it
with the patient standing, have them actively flex their arm above their head, looking for any pain. If the patient has pain, you can correct for a possible anterior glide by placing one hand on the scapula and the other hand on the anterior part of the humeral head. Again, have the patient actively flex their arm while you apply a posterior glide to the humeral head,
okay,
looking for a decrease.
And important is you want to make sure you stay in line with the joint, right? So as you're going up, you're kind of just doing it, and it's not a lot of weight. It's very, very gentle. You're just kind of creating a gentle posterior glide and see if that changes symptoms, right? If that's the case, and it does, what would be another impairment test to check on the table, right? You've now pulled out this anterior glide folder. What other test would you want to do on the table?
Horizontal abduction test. with
Yeah.
the nose.
Yeah, if you have stiff posterior cuff or posterior capsule, that may be pushing it anterior. Good job. What else?
Yale says shoulder apprehension.
Yeah, yeah. If there's enough of an anterior glide, right, it could also call it apprehension, but you may see that they have pain or apprehension with external rotation. You give a posterior glide, it feels better. Right now you have 2 check boxes for it's gliding anterior too much, right? What do we do with people that might be gliding anterior too much?
Stabilize.
Stabilize. Good. What muscle runs through the front that might help stabilize? What muscle runs to the front of the shoulder?
Long head of the bicep.
It's the long head of the bicep. One more that creates more stability. It's closer to the joint line in the capsule.
Supraspinatus.
Not supra.
Pec minor.
Subscap. Right, subscap, right? So your primary internal rotator, right, is your stabilizer. So one, I think somebody said it, you want to make sure they have enough posterior mobility, right? So that's awesome. So horizontal adduction, internal rotation range. Next, do they have enough internal rotation strength at 90? Because that's your primary stabilizer, right? Let's say they have the mobility and they have the strength. Really, it's a control issue, right? Think of most instabilities as a control issue. So we want to look at what's called PICR, right? So it's rotation along an axis. If I put their arm at 90 and they go internal and external, right? Do they have good control? And that's an impairment, right? Just like we can train strength, we can train flexibility, we can train motor control, right? Okay. I think someone raised their hand. I don't know if it was on accident or not. Did anybody have a question? I can't see who it is. It popped up for a second and someone had raised their hand. If not, it's okay.
No questions in the chat, so.
Okay, awesome. Okay, so let's go back. All right, so I'm gonna go to this PowerPoint again. All right, so objective exam to prove our diagnosis. All right, our movement faults, right? Is it scapular? There's 3. Is it humeral? 2. We didn't really talk about thoracic, but that could be another reason, right? If I'm in a lot of kyphosis, that can drive the humeral or the scapular faults, right? If my thoracic spine is flexed, my scapulas tend to be more downwardly rotated, anterior tipped. So maybe we need to work on that, right? Our impairments, right? You guys nailed them. All those length tests, Pec Minor, subscap, lat. The strength tests, lower trap, mid trap, serratus, right? Movement control, right? So what is their humeral rotation? What is their scapula doing, right? And then possibly, is there some joint stiffness, right? Posterior capsule, inferior capsule, scapular thoracic joint, right? Good, okay. All right, so if we come back to here, right? We've done our key findings. Associated impairments would be those things that we treat, right? A lot of them are already buried under our movement faults, right? But we have all of our muscle length assessment. So all of your different muscles, right? All of our scapular thoracic, so serratus, MMT of lower trap, mid trap, scapular thoracic mobility. And then we built a specific category for your overhead athletes, right? There's a lot of studies that show that overhead athletes with any type of arm pain, so shoulder or elbow, there's a lot of impairments that can be treated down the chain, like looking at balance or hip strength, trunk strength, hip mobility that can relate to or cause increased stresses at the shoulder. So it's kind of built in there as well as impairments to treat. But the nice thing is your impairment list should be built around your movement fault link. What are they doing wrong that when I corrected it, it felt better? What drives that? Because patients don't have time, or you don't have the time, right, to test a bunch of stuff, right? And what do you guys think is one of the main reasons, or what's one of the main faults with over-testing impairments and over-testing? What do you think happens?
More damage is occurring.
Okay, So you may be irritating the tissue, especially if they're an irritable patient, right? We wouldn't necessarily tell the patient we're adding more damage because that can maybe make them a little fearful of you. But yeah, if we overtest, definitely we can make symptoms worse. What else?
False positives.
Yeah. How many healthy shoulders out there have weak low traps? How many healthy shoulders out there have a scapular wing? I'll raise my hand. I'll call it healthy, doesn't hurt yet, right? How many people have tight pecs, right? Cameron does 1,000 push-ups a day, right? Can't get his arms behind his head, saves life, right? So you think about, there's a lot of things. If we just keep testing and testing and testing, we're going to find things. You're always going to find things. So now it's messy. I have this impairment and this impairment and this impairment. What do I treat, right? It makes it a little muddy. And that's where when I was a younger therapist, it was the more I treat or the more I test, eventually it's going to become clear. Because right now it's a little confusing. There's all these positive things. So let me just keep looking. And it just, the water gets muddier and muddier and muddier. And then you look at your watch and you realize you have 3 minutes left to treat, right? That's not a good way to practice. So hopefully we can create folders. Good. All right. What about if everything was negative, right? Your active range was negative. Your special tests were negative, right? You did all this shoulder stuff. They're telling you, man, it really hurts when I'm moving my arm. It hurts when I'm working on the computer. My shoulder's killing me, but you couldn't reproduce their shoulder pain. What do you think?
Differential diagnosis.
Which would be what? What would be those differentials?
Kepler says gallbladder.
Okay. Anything else?
Cervical spine, TOS.
Good. Okay. Good. Nice. So let's go with the first one, the visceral referral, right? So yeah, gallbladder, especially if it's the right side, right? More posterior, but yeah, right? Anything visceral internal can radiate and refer. What would be some of our key things we'd listen for that tells us this might be more of a internal organ issue than a musculoskeletal issue? Because there are some very key things to look for.
Changes after eating, what type of pain it is.
Yeah. Changes related to your diet, excuse me, to your diet. So what am I eating? Does it hurt afterwards? If it's like stomach or stuff, is it based on what side I sleep on? Or am I laying down flat? Yeah. So definitely we can ask those questions. And if they're like, no, it's when I rage up, no matter what, it doesn't have anything to do with time of day, doesn't have anything to do with what I eat. Good, right? Good. So I think the other one I heard was TOS and C-spine, right? So with C-spine, what would be some of the key tests? Because now we've spent 75% of our exam looking at the shoulder. We don't have time to do a full cervical exam. So what would be like some key things to look at real fast just to prove that, hey, we know what we're working at? What do you want to test? Cervical spine.
Weiner cluster.
Awesome. Which is what? What is the Weiner cluster?
Cervical range of motion, Sperling's distraction.
All right. Throw one more in there.
Upper limb tension.
Perfect.
Range of motion.
Nice.
Sorry.
That was good. No, good job. Yep. Range of motion, you're looking predominantly at rotation less than 60, right? Upper limb tension test, it's done mostly on median nerve for that Weiner cluster. But if someone's telling me their pain is on the lateral side of their arm, is there another nerve test I might throw in? You guys can type it in or speak it out.
Nerve.
Which one, Sanjay?
Ulnar nerve.
Okay, so ulnar nerve, you think more is going to run down medial inner. Which one runs down lateral shoulder?
Alexander Kern says radial.
Awesome, yeah. You think about your radial groove in between your triceps and your deltoid is in a common peripheral entrapment site, right? And then think about it radiates down, elbow, supinator. So yeah, so the catch-all is median, right? Median has the best sensitivity, specificity. It's what's used in the research. But realize if they're pointing to lateral shoulder and median's negative, shoulder's negative, could be a radial nerve, right? So good. So good. We got cervical spine. We hit our upper limb tension tests. Somebody threw out TOS, correct? So what's our differential for TOS? What's it, if you have time to do one test, what test are you going to do?
Miguel says ruse. Alan says ruse.
Yeah, ruse. Yeah, it's the most catch-all. Does not tell you what to treat, so it kind of sucks in that mind. But it's really good to tell you, hey, at least I know what I'm dealing with, right? So hey, this guy has TOS, right? Ruse. It's really good because you can measure it, right? Start a stopwatch. It's a great reassessment for same day at the end of treatment or the next week they come back in. Every week they come back in. They start off with their ruse to see how long they can handle, right? So that's great, but it doesn't necessarily tell you what to treat, whether it's like Pec or whether it's caries or first rib or scalenes or whatever it may be. It just tells you, hey, there's something wrong with the brachial plexus vascular bundle. All right, cool, good job. So hopefully if we go down the shoulder route for rotator cuff, we found something related to shoulder. If not, our backup is cervical, maybe nerve.
Dr. LeMoine, why ruse over AdSense?
Because ruse has the best sensitivity. I mean, if it's negative, rule it out, right? AdSense is very specific, right, for scalenes. So let's say it's a pec compression or a costeroclavicular compression. It's not scalenes, then you might not pick it up, right? AdSense is for scalenes specifically, right? Now, when I said ruse is sensitive, I mean, if it's positive, doesn't necessarily mean it has to be ruse. It could be other issues like shoulder impingement or this or that. But it means if it's not positive, you can say it's not ruse. Good question. Okay. All right. So if we come back, physical exam, interventions, right? So if we were going to do manual therapy, right, ideally we have to decide, okay, which fault did we put him in? What impairment did we have? Right. So what are some of the common impairments we're treating with shoulder impingement? Right. If I'm going to do mobilization with movement, right, I'm going to be doing what? What directions do you think I'm going to be doing?
Inferior glide, posterior glide.
Yeah, so those are the most two common ones. So if I have a limited range in elevation, limited range in rotations, yeah, I may be looking at joint mobility. Think to what did we do during our objective exam that made them reach better? We changed something along the way, right? We changed upward rotation possibly. We changed the posterior tilt, right? So our mobilization with movement, it may be, I'm just helping them with upward rotation, right? As they're going into shoulder flexion, I'm just giving them upward rotation, or I'm giving them a posterior tilt, right? The goal is it doesn't have to be a glenohumeral mobilization, right? That's kind of the trick, right? Is that we're taught in school that, hey, mobilization, lay on the table, open pack position, mobilize the shoulder joint, right? Shoulder joint is not just glenohumeral. So whatever you did in your objective that helped them, you can make that your exercise or your manual therapy. On the table, if you found the stiff capsule, by all means, right? Make the shoulder more symmetrical. That's good, right? So that would be your mobility, posterior inferior. Remember, we assess scapular thoracic, right? Possibly it's stiff. You need to work on that. Soft tissue, right? Studies show that after you work on soft tissue, right, mobility improves, right? Blood flow to the area makes things more elastic, heats it up. So whether we need to work on posterior capsule, some of the posterior rotator cuff muscles, here we might be working on the pec, right? Because that improves tipping. If someone had an internal rotation problem. So again, the goal of this is not just to pick and destroy, right? Everybody has tender points. It's, you know what? This person had an internal rotation when they moved. It felt better when I externally rotated them. What are those internal rotators that might be stiff? Let me see if there's any trigger points in there that I might need to work on before we stretch, right? Get more bang for your buck, right? Add a little bit of hands-on before you start working on stretching. Good. And of course, if it is the extension person, right? Let's say it's a person that's kyphotic, right? They're raising their arms up. You sit them up nice and tall. They recheck and like, hey, I feel better, right? This is when we get to pull out some of our fun tools and say, all right, maybe we do some snags, some grade 5s, some thrusts to the upper thoracic or the mid thoracic. Distraction. You have some options to work on that. Good. So that's manual therapy, right? The job of manual therapy, improve mobility, make things move better. If that was our primary finding, meaning our MMTs weren't that bad, then we're going to send them home with mobility exercises, right? So what do they do? So what if I'm trying to improve posterior capsule mobility? What would be some of the big go home and do exercises for someone with posterior capsule stiffness?
Sleeper stretch.
Sleeper stretch. What are some of the issues with sleeper stretch?
Diana says not as good for overhead athletes. Diana Wallace says getting into the position.
If I take someone and I put them on their side, shoulder to 90 degrees of flexion, I internally rotate it. So it looks like that. Does that look familiar to any special tests? Right, what test does that look like?
Sanjay says Hawkins-Kennedy test. Reston says ouchie.
Exactly, yeah, exactly. So if we're cranking on someone's shoulder and they have impingement, we're really just putting them into those positions. So we want to make sure that, yes, studies show this is a great stretch for posterior capsule, posterior cuff, but we want to make sure, where do you feel that at? Because if they're going to be like, oh man, that hurts, we're going to be like, yeah, you're really stretching it. Way to go. Keep working through this. Is it in the front where they're pinching, or they feel it where they're supposed to feel it, right? Because if it is, we don't want to send them home with that. So then you can kind of do what's called a roll off, where instead of being in flexion and they're laying on it, just have them roll back a little bit. It's not pinned down as much with their pressure, but now they're no longer in flexion and they're in scaption, right? They did a study that just compared subacromial space here versus subacromial space here. It's more open, right? So they can still stretch it. Otherwise, horizontal abduction, arm across body, improves this just as well, right? So that would be our posterior capsule. Good job. How about if we're trying to improve our medial rotators? So meaning that would be our subscap, our supra, sorry, subscap, no, what thing? Our subscap, our pec, and our lat, right? You guys all have shoulder stretches for those? Right?
Soft tissue with the tennis ball to the pec region.
Awesome, right? Anytime we do soft tissue, what do we have to follow it up with? What do you think?
You gotta stretch it.
Stretching or active range. Doesn't have to necessarily be like a hold, but soft tissue by itself, studies say 5 minutes later, you're back to the same. 5 minutes, no change. So if I'm going to soft tissue someone, it's either A, I'm going to follow up with a stretch, or B, just having them move, right? It's like if you guys go to the gym, you soft tissue your quads. Hopefully it's before you're doing squats or lunges or running on the treadmill. It's not just, hey, I'm going to soft tissue my quads and go sit on the couch, right? Don't get nearly as much out of it. Good. So for our, all right, we have doorway, subscap by your side, wall slides for your lats, keeping the external rotation, right? Lat stretching. Good. If we're working on Pec Minor stretching, right? It's trying to get that Pec Minor, right? We don't necessarily need to go above our head because that's Pec Major. When I do this, is my Pec Minor stretching? Yes. You can't stretch your Pec Major without your Pec Minor. However, you think people might have shoulder pain? They're stretching up here. So then like say, you know what, just keep your arms by your side and stretch your pecs this way where you're less likely to impinge tissue, but still get a good stretch. Okay. What's the benefit also of if I have someone do this in a doorway, right, stretch at 90, versus someone putting their hands behind their back and then doing a Pec Minor stretch this way? What else is the added benefit of doing this one?
Thoracic extension.
Good. So again, thoracic extension. What muscles are working?
Rhomboid activation.
Rhomboid activation. Yep. So all those scapular muscles back there, right? Now, if somebody has an anterior tip scapula and we're trying to posterior tip them, right? So we're stretching the Pec Minor to improve this. What muscle do we want to cue them to use?
Lower trap.
Yeah. So instead of just being generic and say, you know what, squeeze your shoulder blades together, which is rhomboids, mid-trap, better than nothing. You're still getting good stability. Maybe we could cue them, right? You know what? Put your back on the wall and see if you can try to get your scapula to tip backwards, tip down, versus just this, right? Do they need to work on retraction? Maybe not. right? So again, can we be a little bit cleaner, a little bit more specific for this patient? Good. All right, so that's our mobility. Motor coordination. The nice thing here is we have patients at different phases, right? So if someone is highly irritable, right, we want them to move their arm unless it's a fracture, right? Or there's some type of trauma and it's within those first 2 weeks. Otherwise, every shoulder pathology, get the arm moving, right? Get the arm moving. So if it's highly irritable, it's more motor control. It's below 90. It's turning on muscles. As we get higher, some more moderate irritability, not that bad. They're reaching higher. And then lastly, maybe more higher level strengthening and higher level body blades, added resistance, stuff like that. So you kind of, it's broken into phases based on thorax. Here it's broken into categories. So I like this a little bit better because again, it tells me if I was working on their scapula, that's what made them better, right? What am I going to work on? And it has exercises for each category, right? If it was the humeral head I was working on, right, it was an anterior glide, has exercises to match, right? If it was the thoracic spine, right, I have exercises to match. So again, our thorax should match the category. It should match the category that we put them into based on what made them feel better. Okay.
Dr. LeMoine, quick question with the thorax. Someone asked, would a, like sinking into a push-up or a plank position put a relatively posterior glide in the capsule? Or do you feel like you could better exercises that you could pick?
I'd say there's probably better exercises that would create extensibility of the capsule, like reaching across. But yeah, when you go into weight bearing, right, and you go into it, you're definitely hanging on posterior capsule. So if you really think that's your impairment you're trying to change, you can definitely do it. There's some like high level, there's some high level weight bearing posterior glide exercises where they're in this position and then they're turning their shoulder towards it. So now they're weight bearing, get that posterior glide, and then they're adding that horizontal adduction, but it's in weight bearing. So they're like turning their body towards it and it's pretty intense. So as long as you feel it in the right spot, right, all your body weight on adduction. So the thing though is we just want to make sure that it's not anterior pinching, lateral shoulder pain. It's like, hey, does that feel like something's being pulled apart versus pinching? So good question. Yep. Good. So functional stuff, right? So whether it's overhead throwing, return to weightlifting, just a general education about, right, elbows in, shoulders out, stuff like that. Sleeping, that's a big one, right? People have problems with sleeping, right? People like to sleep on their side, put their hand in certain positions. So we want to make sure we're educating them. We heal when we sleep, right? We're less stressed if we have a good night's sleep. Improved cortisol levels, which make inflammation levels better if we sleep better. Right? It's getting dark in here. Sun went down. Okay, cool. All right, so we've kind of walked through objective exam, interventions, stuff like that. Patient education, right? So what's going on? How long will it take, right? The nice thing is we actually have a patient education app. Shoulder impingement, rotator cuff tears. So the nice thing about this is patients come in and they're told you have a rotator cuff tear, right? We want to know, right? All that information I just told you, we can email that, right? We can email that to patients, right? So just click on the little email thing and it goes over some of these rotator cuff, how common it is, how a lot of people don't get surgery. A lot of people do better without surgery and they do fine. And some of the key exercises that people work on. So it's a good way to just kind of send that to them. And then same thing for shoulder impingement, right? It's a 2 to 3 minute read. It has a video with it and it can just be emailed to the patient. I would say this shouldn't be your only form of education, right? You want to talk and educate patients, have that conversation because then they have more buy-in into you, but patients only remember 30% of what we say, right? According to studies, 30%. Think about how much we said in that exam. They're going to go home and their significant other is going to ask them, so what'd they say? And they're going to be like, my shoulder hurts. I don't know, right? So we want them to remember some of these things about why impingement happens and what are you going to do about it. So some of the key exercises that are kind of, and then the articles. Okay. So that would take us through our clinical pattern recognition and our patient education. If you don't want to go down that whole entire, I don't know, pattern, and you just want to look at special tests, right? Here at the shoulder, right? If I'm thinking rotator cuff tear, what are those big four? What are the big four tear tests? See if you guys are paying attention.
Drop arm.
Intra-rotation, extra-rotation lag signs.
Drop arm.
Drop arm, right? And then what else? MMT by side, right? So that would be arbitrary. How about our subacromial pain? What are our impingement tests? Right.
Positive arch sign, positive hot density, positive pain, MMT.
Good, perfect. Those by themselves aren't nearly as valuable as grouping those together, throwing in nears as well. And then we start to say, okay, if they're all three positive, all three negative, we can be pretty confident, right? That's good. Okay, so let me go back to this. All right. So we talked about our recognition. We talked about our primary faults, our associated impairments. Here's the two patient education ones, right? We talked about conservative care being very helpful, right? You guys remember who actually does better with surgery? Who's the person you'd want to refer out?
Under 40 and active.
And trauma, right? Who's somebody that isn't going to do well? And this list was actually quite long. The people that do well, the small list, unfortunately. The people that don't do well had a very long list. I threw out a couple of them, but do you guys remember them?
Over 50.
So age, the older they are, non-trauma.
Comorbidities.
Good, yeah, so diabetes, they're a smoker, right? So this is, in this article, the one that looked at the 5-year follow-up without surgery, right? So based on the size of the tear, so small, medium, large, massive, right? Obviously, the larger the tear, the more re-tear rates and the worse they did, right? Kind of makes sense. So if someone comes in there telling you, I have a 1 centimeter tear on an MRI, you're going to be like, oh, you're better than the majority of people out there. Great job. You have good prognosis. I can help you, right? Because based on their age, small tears, these are people that got better, right? Versus massive tears. If they're 80 years old and they have a massive tear, right? That tear is not going to heal. But this is like people like, why would they do surgery on it if it's not going to heal, right? It's so far apart, and that tissue is 80-year-old tissue, right? Not being ageist, but just being realistic, right? Whatever. Good. All right, let me see. I think that might be it, guys. Cool. Yeah. Is there anything I didn't show? I think the only thing I didn't show on here was, let me go here. Subacromial pain, interventions, modalities, right? So the modalities for impingement, right? There's no evidence to support modalities for impingement, right?
Huh?
Right? So you think about like ultrasound, E-stim, those are purely for symptom management. So if someone has a lot of pain, it's not saying don't do it. And if that's your primary treatment and that's it, it's not, there's no evidence to support that. But it is very helpful for just pain treating.
Right on.
You know what? I'm trying to do extra rotation strengthening and it kind of hurts. You know, sure, let's throw TENS on there. Let's throw ice. Let's do that stuff. And then let's do our strengthening, right? Sometimes we have to do a little pre-stuff first to get to the meat and potatoes of it, right? Give people appetizers. There's some good studies that haven't been done enough to see how long they work, but think about how much we use NMES for quads, right? There's research to support that stuff like crazy, right? ACL, total knee, patellofemoral, right? You can put NMES on people's quads and it's very valuable. So now we're starting to put NMES on people's mid-trap, lower trap, serratus. It hurts a lot more because there's not as much muscle belly, right? But as they're reaching, right? You're turning on their serratus to get more upward rotation, right? So you can use it. It's just hasn't been out there long enough to have some good studies to back it yet. But there's some people at some universities that are using it, right? So the thing we threw in was just taping, right? So taping to improve that motor control, which then again, that leads them to still doing exercises. So think of it as like taping someone's patella femoral. Taping in itself isn't the thing. It's they tape them so then they can exercise with less symptoms. Right? Cool. All right. Any questions, guys, or anything that wasn't clear that you want me to clarify? Or any video you want me to show? Or here's one for you guys. Prognosis, time-wise. How long do you think it takes for someone with a full rotator cuff tear to improve conservatively? Right? This person that had insidious onset, just shoulder's been bothering me for a couple of years, just got worse and worse and worse and worse. 55, relatively active, but we're saying, you know, you might not need surgery. You'll do good without it. How long do you think it takes them?
4 months. $16 to 20 weeks.
Higher, longer.
1 year.
6 months. Not that high. Good guess though. So 6 months, right? So even though we're treating them conservatively, 6 months. If someone has rotator cuff surgery, how long are they in rehab for?
We have 12 weeks and 4 weeks.
If someone has rotator cuff surgery, right, it's 9 months for the moderate tears, a year for massive tears till they're back to normal. Doesn't mean they're in rehab the whole time, but it takes a year for them to get back to, hey, I want to be able to paint my barn, right? Not to feel, I don't know, painting my ceiling. There you go. It takes a while. So both groups take a while. So it's not like all of a sudden, hey, don't have surgery, you'll be better in a week. It takes a while, right? Yeah, cool. All right, cool. Cameron, Chris, did we miss any questions on there or anything?
Oh,
I think we covered everything. No further questions in the chat. We did get a couple early questions at the beginning, just asking about the lecture slides. And just so everybody knows that whoever attended the webinar tonight will get a follow-up email with the slides. And then also we'll put in some notes, some key notes that we've kind of highlighted, or Dr. LeMoine highlighted throughout the webinar, just so you guys know.
And then we also, I recorded the whole thing, so we have it. So I don't know if that's being sent out as well or not. Chris, you guys figure out. Cool.
Yeah, we'll let you know about sending out the webinar as well.
Cool. All right, so the next one we're doing is on August 11th. I need it, and we're doing 7 p.m., right? Not 6? That's my fault?
Correct, 7 p.m.
All right. I was definitely on here at 6 p.m. and I was like, all right, I'm ready to go, guys. He's like, wait a second. All right, I was an hour early. So I apologize for everybody on the East Coast who's now in 11:15. Okay. All right, so I'll see you guys in a couple weeks. And we talk about hip stuff, mobility, but also non-arthritic wise. So more like FAI versus like osteoarthritic stuff. Okay, cool. All right. Thank you guys very much. I appreciate you guys all from, feel free to shoot me an email or attach anything at our PhysioU Instagram account, and we'll get back with you guys.
Dr. LeMoine?
Yes, did someone ask them?
Yes. Can you hear me?
Yes, I sure can. Is this Sanjay?
All right, cool. Yes.
Hey,
Quick question. So if someone had the full thickness tear and you're kind of educating them at the very end, and you say, let's, in order to feel kind of back to normal, you have 6 months, and then let's just say, and you'll see them in clinic for, let's say, 12 visits. And they ask, what if I'm not 100% by the time of discharge? Or how do you kind of correctly gauge discharge if they're technically not back to normal? I mean, of course, your functional goals and everything are to be considered in, but what if, would you consider, how far of an extension would you consider going with therapy if they're not, I guess, into that normal if that makes sense. Sorry.
Yeah, I think the unfortunate answer is like, right, obviously it's very dependent on your insurance type, right?
Sure.
If you're at a place that you don't have to worry, like, so within Kaiser, I get to say where I work, I get to say how many visits that person gets. I get to see how often they come in. And so I can have a little bit of control of that. But right, if you're at a private clinic and it's private insurance and stuff like that, they'd be limited in certain things. So you have to decide, this is going to be a long process. Where do they need me the most, right? Early on, they're in a lot of pain. They really need to just help get out of pain and then just start to learn, how do I even move? So at that point, like, you know, we're going to spend the first 4 weeks, right, really trying to get you to be able to just get active range of motion, right? That's you working on your MWMs, your soft tissue, getting them. And then you're like, hey, you know what? This next 3 to 4 months is going to be all about getting stronger, right? So I don't need to see you every week, every other week, right? So here's your program. This is what you're going to do for the first 2 weeks. If that's good, you're going to add this for the next week, and I'll see you in 3 weeks or a month. You know, so you might have to push it back. But again, that's me saying I've already set the stage with what is healthy, normal movement. Do they have good motor control? They have good flexibility of stuff. But now it's like, hey, here's your program that you're going to go to the gym. Just like we don't go to the dentist every week. We go, right? You go, they do your checkup. Here's your plan. Floss, brush your teeth, come back in 6 months, right? So I think that's how we might have to set it up. And that's how I do set it up with people that have a financial burden. So even within Kaiser, where I don't have a limitation appointment, if it costs them $80 for their copay, right? Which it may be now with certain health insurances. Like I understand that. And I tell them like, hey, right, we will set up a home exercise program where you're coming in, right, once every 3 weeks. And if you didn't do your home exercises for 2 weeks, push your appointment back 2 weeks, right?
Sure. Yeah.
So, but it's a tough situation to be in because we want to help people, but we realize there's ceilings based on what we get reimbursed for, and we got to keep the lights on somehow, right?
Absolutely. Yeah.
So, good question though.
Thank you for that.
Yeah.
Also, just to give you some feedback, I really enjoy these webinars. They really teach me how to like use the app a lot better. And
man, appreciate it.
Yeah, just giving you some feedback. It's really helping understand how to use the app better, and just helps with clinical reasoning and just developing into a better clinician. So thank you, really.
You're welcome. Thank you. If there's any ever constructive feedback, so anything you think that we can do to make it better, I'm all about it. Right. Sure.
I've had some ideas. I wanted to reach out to you, and I don't know if you ever thought about with your Therex. What you have on there is great, but in terms of progressions, did you have any ideas about putting more progression-based videos with certain, let's just say glute med. You can show clamshells, fire hydrants, and then getting into like, let's say like glute med hip hikes or certain things like that.
No, yeah, like following some of those like articles that talk about muscle activation, or even like Chris
Dr. Powers, yeah.
Yeah, we thought that we definitely include a lot of them in there, but it's I would agree it's not necessarily maybe organized in that way, at least for level. We do have that in like some of the shoulder pathologies. It's organized in like low, middle, high, or high irritability, low irritability. But as far as like amount of, let me get out of this, like amount of like muscle activation, right? Like we don't have it set up that way. So if I just go to all Therex, right, resisted, oh, that didn't work. Yeah, so we kind of just have stuff, glute med facilitation, glute max, hamstring, hip abduction, strengthening. Yeah, they're not necessarily organized in a way, like we have lots, but yeah. So that's a good thought. That's a good thought. Because nice thing is you don't have to necessarily film any more videos. You just have to go.
Right.
Say, hey,
that's the hard part.
Let's see. I'm looking for patellar femoral. That'd be nice. Conventions. Therex. Oops, nope. Motor coordination. So arch. So corrective exercises. Hamstring, gluteal strengthening. So glute max, right? So facilitation, strength. So I guess it's kind of in the 4 that we have for glute max. It's a little bit organized in like, hey, can they turn it on? Can they work against gravity? Can they work against resistance? Can they work in function? It definitely could be more extensive, right? And this is kind of the same thing, right? So facilitation, clamshell for half leg, full leg, and then Brugger stuff. Yeah, I can definitely, think about how many exercises are out there that facilitate glute stuff, deadlifts and bridges and stuff like that. So
sure, absolutely, yeah. It's just a thought, yeah. And also just closed chain versus open chain exercises, or the progression with that.
Yeah, that's definitely a way that you can organize it and be like, hey, no, I appreciate it. Yeah, if you ever, if you shoot that in an email.
Yeah, definitely. I'll send it to you right away. Yeah, of course. Also, I'm not sure if, were you with, I know everything on this app is very evidence-based and like backed by articles, which that's even more power to what's on the app. But say for the exercise, like let's just say, for example, a squat, are you looking, like say if you did start including more progression-based exercises, do they all have to be necessarily like backed by like a certain article to say, hey, at 90 degrees of knee flexion in a squat, the EMG of this muscle is shown to be more active? I don't know if you're, like all the Theric space has to be evidence-based.
All of it. I mean, some of it clinical. Clinical
right.
bias. We try to. I mean, if there's articles for it, we include it. And if it comes down to like, hey, hey, we're going to only include 5 Theric videos because we don't want, because you could just put tons and tons and tons.
Sure.
And like, we're splitting hairs, we'll choose the one that has some evidence-based.
Okay.
Okay. And then I know anytime we do like our mentoring minutes stuff, right? So like our knowledge, right? I don't know if you've seen any of the mentoring minutes where it's similar to what I just did today, but it's not using the app. It's more just saying, so I should have done rotator cuff today. So rotator cuff rehab. It's only evidence-based. We just pick out like 2 or 3 systematic reviews and we read a couple hours. It's like a 4-minute video of the evidence-based for, so this one's rotator cuff rehab, the diagnosis of it, the rehab of it, the outcomes. So that stuff is very much, but in the app itself, there's definitely stuff that we include. And when it gets to the references at the bottom, it just says there is no evidence to suggest or to support this.
Okay.
It's like some disclaimer. Yeah, disclaimer. But our goal is to try to stick to evidence-based. Like that's kind of what
absolutely.
Right? So
yeah, I agree 100%.
A lot of things that from being in the clinic 12 years that people have gotten better with that I can't find an article to back it up.
Yeah, no, it's just it's hard with keyword searches and everything sometimes has to be really precise in order to find exactly what you want. So totally get it.
Yeah, cool.
All right, thank you so much.
Of course. All right.
See you for the next one.
All right, see you in a couple weeks, Sanjay.
Take care.
And unless anybody else has any other comments or questions or anything?
I've got a question if you have time.
I do. Who is that? Alyssa. Hey, how are you?
Good. How are you?
Doing great.
Question. We learned about rude techniques in neuro, like quick ice or like using the vibration machines. How often are those used in like an outpatient ortho setting?
The only time I ever use it is like with the Bell's palsy, right? Because there's some stuff that you're not supposed to put like you're trying to facilitate muscles and it's technically like a neurological thing, like a virus on the nerve. I think that's the only time that it's been used. Otherwise, it's not. I'd say I use tapping a lot. So like if I'm trying to get someone's glute or quad to work, like I'll definitely like tap it and kind of punch it and try to facilitate it. But I don't necessarily use ice in personal preference maybe, but I don't necessarily see it in the clinic with any of the other 30 therapists out there working. You don't see it in the literature for orthopedic stuff. Not saying it doesn't work. Not saying it doesn't work. Just don't do it. I don't do it.
Can I follow that up, Dr. LeMoine? You see a lot of new clinicians using like Theraguns, hypervolts out there for facilitation, especially like glute med facilitation. Is there any research that you've seen that kind of stands out to you that actually is a good technique to utilize and kind of worth spending the money on some of those devices?
I've read, there's 2 studies that come to mind, but they both didn't really have a control group. So you're just saying, hey, if I do this, do patients feel better? So there's no deep studies that I've read that says yes, besides a subjective concern or subjective thought of, hey, I feel better. There's nothing that shows, oh, the muscle is actually more extensive through ultrasound, or the muscle fired at a higher EMG rate, or we did Theragun versus NMES and Theragun was better. Like there's nothing that I've seen out there that compares things. So it's just saying, hey, there's improvement, but the studies aren't good yet. And also it hasn't been out there that long. So most of these early studies are done by students that have limited resources, limited time, right? And they're doing it for their doctoral programs. So sometimes they're not the highest level of evidence, but I'm sure it will come. But do you think, I think there's, on the whole other aspect of it though, do you think patients benefit from it?
I think they get buy-in.
If patients think they're going to get better from it, are they going to get better from it? Totally.
Absolutely.
So if they think that this is what's going to help them, and we know that pain is a central processing issue, regardless of what your issue is, maybe biomechanically and musculoskeletally, doesn't change a dang thing. But if it changes neurological processing, right, and they feel like, hey, I feel like I can activate better, I can move better, I'm less threatened, that's helpful. I'll take it, right? Patients are getting better. We don't want to oversell it and be like, this is what you need, it's what you have to do. Right. There was one thing I read about it. If you're supposed to teach patients are supposed to be taught to use it themselves. Because if you use it yourself all day long, it can damage some of the nerve fibers in your hand, that constant vibration over and over and over. So like, let's say you're using it 3 hours a day on different people. So you're supposed to teach them to use it because people have been complaining of numbness and tingling in their fingers from using it too long. So I was like, oh, it makes sense if you think about it, I guess, right? Constant vibration on your hands. Cool. Good question, Chris. All right, guys. Any other questions? Alyssa, are you good? You good? All right. Thanks, guys. Thanks for everybody that stuck around for an extra 15 minutes for questions. I know it's late in places. So I will see you guys soon, and I'll change that PowerPoint to 7 p.m. before I send it to you, Chris and Cam.
I can do that, Dr. LeMoine. Good night.
Good night, guys. Take care.